Good evening, and thank you for joining us for tonight's webinar, This Too Shall Pass, Treatment and Metabolic Management of Kidney Stones, presented by Dr. Matthew Steinway. Dr. Steinway earned his medical degree from the University of Arizona College of Medicine. Dr. Steinway has been a board-certified urologist since 2011 and joined Arizona Urology Specialists in 2017. He practices in our Scottsdale office and specializes in kidney stone, metabolic management, prevention, and surgery. Welcome, Dr. Steinway.
Thank you. Thank you very much. And thank you all for joining us tonight. We're going to be talking about kidney stones, which is definitely one of my areas of interest, and talking about diagnosis, prevention, and treatment. Just a brief background on myself. In the introduction, I kind of covered where I came from, but on the side here are some of the areas of interest of mine. But number one, you can see is kidney stone surgery, as well as the metabolic management and prevention of stones, which is what we're going to focus on tonight. So as I mentioned, we're going to go over the diagnosis of kidney stones. We'll talk about treatment options and then focus on prevention. So starting with diagnosis, a little bit about the background of kidney stones. The overall risk is about 10%, and it's actually going up. The numbers are closer to about 11% now, and that accounts for about 1 million stones per year in the United States. Females tended in the past to have more predominance for stones than males, although this seems to be equalizing for some reason, which we don't totally understand. But we are seeing an increased incidence in children over the last several years. And in general, the stones tend to be focused more in the southern United States, possibly related to the weather and or dryness, as in Arizona, we're clearly in the dry desert. Initially, most patients that have kidney stones present with pain, abdominal pain, flank pain, that sometimes can be radiating down into the lower abdomen or into the groin. It tends to be a colicky pain, kind of an on and off pain. Many of the people watching this video may have already experienced that in the past. And a lot of times there's associated symptoms like nausea and vomiting. Some people actually see blood in the urine, or there can be microscopic blood. Occasionally there can be a urinary tract infection that's associated with the stone, which can sometimes be related to fevers and cause fevers. Larger stones, stones that may not initially be able to pass down the ureter, can also be associated with recurrent infections, more of a dull, achy pain, and prolonged large stones can actually lead to loss of kidney function. In general, the initial evaluation, and this is often done in the emergency room or urgent care, is checking a urinalysis, a complete blood count, and a basic metabolic panel. The urinalysis looking for blood that may go along with the abdominal pain to then do some further imaging studies. Blood count to look for a white blood count that could indicate an infection, and the basic metabolic panel to look at the kidney function and look at electrolyte abnormalities. And as I mentioned, imaging is really the main way that we diagnose kidney stones. You'll see here KUB, or kidney, ureter, bladder X-ray, renal ultrasounds, and CT scans are all used to make that diagnosis. And as I mentioned here, it's important when we're making that diagnosis to rule out other similar diagnoses, things that could present similarly with abdominal pain, things like appendicitis, an ovarian cyst or torsion, or diverticulitis that can sometimes mimic a kidney stone. Briefly, the anatomy of the kidney and the ureter. So on the left, we have the kidney here, and you can see it's broken down mostly into the cortex, which is the more urine-forming portion of the kidney, and then the calyces, or the urinary collecting system. And these are branched into multiple calyces, and they converge into the renal pelvis, and the urine then flows down the renal pelvis, down the ureter, toward the bladder. On the right is a picture of the kidney with the ureter. As you can see, there are three narrowings along the course of the ureter: the UPJ, or the ureteropelvic junction, the iliac vessels, which are the large vessels that branch from the aorta and the inferior vena cava, and then the ureterovesical junction, the UVJ, which is the distalmost part of the ureter as it enters into the bladder. And these three areas are the most common places where kidney stones tend to get stuck along the course as they pass down from the kidney. So some examples, as I mentioned, the different imaging studies that we use to diagnose kidney stones. So KUB, again, kidney, ureter, bladder. This X-ray here shows a patient with very large bilateral, you can see on the right side here, you can almost see the outline of the kidney with large branching, or what we'd call a staghorn kidney stone. And then here on the left side, similarly, very large branching kidney stones. Most patients don't initially present like this. This is just an example of an X-ray that pretty drastically shows stones on a plain X-ray. We also utilize ultrasound of the kidney. In this case, the outline of the kidney is shown here, and obviously the big yellow arrow is pointing to this white density here that seems to be corresponding to a stone. And one of the ways we can acknowledge that is seeing this shadowing behind the stone that corresponds to the ultrasonic waves that go from the outside of the body toward the stone. And then most commonly, CT scans are used to make that diagnosis. The CT scans are often presented to us in multiple views. So here we have an axial view and here we have a coronal view. So this is as if we would be looking directly at the patient. On the left kidney here, you can see that there's a stone, this white area that's just exiting the kidney at the ureteropelvic junction. There's also a lower pole stone in this picture as well. And then down here is the bladder, just to give you the orientation. On this side, this is as if we're standing at the patient's foot looking up. So again, here's the right side and the right kidney, and here's the left kidney with that stone right at the ureteropelvic junction. So now that we've made that diagnosis, the question is, how are you going to treat it? And first question is, who needs intervention? In general, patients that have an obstruction or a blockage, especially when they have an associated infection, can be emergencies. Someone can be very, very sick with an obstructed infected stone, and that typically requires acute intervention, usually not to remove the stone, but usually to drain the infection first. Patients that have renal deterioration or potentially have loss of kidney function are definitely candidates to have surgery for stones. Patients that come in with intractable nausea, vomiting, pain that's not controlled with oral or IV medication, but also patients that have a solitary kidney. Either they've donated a kidney or they've had a kidney removed for cancer, or maybe they were born with a solitary kidney. If they have an obstruction of that one kidney, they can go into kidney failure, as well as patients that have stones in both kidneys with obstruction. So I've had patients recently that have had ureter stones on both sides causing obstruction to the point where they were in kidney failure. And then, of course, patient preference. Some patients, if they're going to be traveling, if for work, sometimes we'll have to more urgently intervene for certain patients. And the options in general for treating stones, number one, surveillance. So we don't necessarily have to operate on every kidney stone. A large percentage of stones, especially the smaller ones, are very likely to pass. So we'll often give them that trial of passage. And one thing that we can do to help that potentially is medical expulsive therapy, medication where we can give the patient to try to help that stone pass more easily. There's been some debate in the literature about how much or how beneficial that is, but in general, it's thought to have some benefit to the patient. And if you're more likely to pass a stone and avoid a surgery, I'm all for it. Dissolution. So there are some types of stones that we can dissolve medically, but there are very, very specific circumstances where we can try that modality. And then lastly, surgical treatment, and I'll go through some of those options with you. As I mentioned before, the size of the stone, smaller stones are more likely to pass. In this table, you can see that a stone that's 2 millimeters or less has about a 97% chance of passing, or only a 3% need for intervention, whereas a stone that's greater than 6 millimeters has about a 99% chance of needing intervention down the road. So the smaller the stone and the more distal, meaning toward the bladder the stone is, the more likely it'll pass without needing intervention. As I mentioned, dissolution or dissolving the stone based on the stone composition. So really, uric acid is the primary stone that we can try to manipulate the parameters of the urine to break it down and dissolve it. Really, the name uric acid stones form in acidic urine. So the way we dissolve it is to alkalinize or raise the pH of the urine up to about 6.5 or higher so that we can get that stone to dissolve. Typically, that's done with potassium citrate. Occasionally, we use sodium bicarb as an option. And then much less common type of stone that potentially could be dissolved, although it's very difficult, are cystine stones. This requires an alkalinization much higher of at least 7.5. Also, we use potassium citrate. This is a little bit more difficult. However, it is a more rare type of stone. The most common type of stone, calcium oxalate, unfortunately cannot be dissolved. And so that's when we talk about surgical treatment. And the main types of surgical treatment options that we have, there's extracorporeal shockwave lithotripsy or shockwave therapy. You may have heard of that. There's ureteroscopy with laser lithotripsy, where a scope is put into the ureter, hence the name ureteroscopy. And we use typically a holmium laser to break up the stones. There's percutaneous nephrolithotomy. We'll go over some of that as well. And then rarely do we need to use either open or laparoscopic or robotic surgery anymore for kidney stones. It used to be a standard treatment, and that's become much less common with the advances of technology and the size of the scopes and things that we're able to accomplish. This is a picture of the setup of a lithotripsy machine or shockwave lithotripsy. And hopefully you can see on this slide, here's a patient laying on the table. This C-arm here is the X-ray machine that shows us exactly where the stone is, and we can manipulate that to identify the stone in 3 dimensions. And we can see it here on the screen, and you can see the crosshairs where we line up the stone so that we can send the shock waves directly and blast the stone into pieces. This is a little bit of a grainy picture, but essentially it shows the yellow stone here in the background. And this is the view from a ureteroscopy from a scope in the ureter. At 6 o'clock on the screen is the laser fiber with the light on the laser lasering and breaking up the stone. You can see there's a little opening in a little hole in the stone right here where we had lasered as well. So under direct visualization, we can break up and basket and remove pieces of the stone with ureteroscopy. And then I'd mentioned percutaneous nephrolithotomy, or PCNL. This is a schematic, obviously, of the procedure where we can put a tube directly through the back into the kidney through one of the calyces, and then be able to remove larger pieces of stone from above rather than have to work through a much smaller tube from the ureter from below. I'm going to show you an example of a case that we had done a percutaneous nephrolithotomy on. I showed this picture earlier in the presentation, but you can see a very large, what we'd call a full staghorn calculus, basically filling the entire collecting system, all the little calyce divisions. And here's the kidney as it tapers down into the ureter, the renal pelvis into the ureter. And in order to accomplish this case, because of the size of the stone, we actually went through 2 different approaches, 2 different accesses, one through the lower pole of the kidney and one through the mid pole here. And you can see these tubes and wires going down the ureter. We actually had 2 scopes going into the kidney at the same time, myself and one of my colleagues, where we had a flexible scope and then a rigid scope breaking up and removing stone. And we took a series of x-rays as we did the procedure, and you can see the majority of that stone has been removed after that portion of the procedure. Obviously, there's still a large amount of stone left, but with this size and amount of stone, this was quite an accomplishment. This is just a picture of that case, kind of showing the size of the scopes going through the patient here who's laid prone on their stomach, and this is going in through the back here and using either a flexible scope or a rigid scope to be able to break up and remove those stone fragments. A brief word on stents. That I often get a lot of questions about stents. We often use them either for an obstructing stone initially, especially if there's any sign of infection, but often we will place a stent after ureteroscopy. It's optional, but it also depends on the surgeon at the time of the procedure making that decision. It's composed of polymeric compounds, it's a plastic, and it's a temporary stent, not like a heart stent that would stay in the patient's body forever. And now on to prevention. You can see the big glass of water, so you may have an idea of what's coming on here for part of the discussion. The main things that we look at for stone prevention that help us put the whole picture, the whole story together. Number 1, stone analysis. So what kind of stone is it? Once you've passed that stone or once we've removed it surgically, what kind of stone do you have and what can we do to manipulate the parameters to reduce the likelihood of you continuing to form those stones? And number 2, the metabolic evaluation, some 24-hour urine studies and blood work to also help put that story together. And we don't always have both. So sometimes patients will pass a kidney stone and not collect it. And so we have to base our decisions off the parameters found on the metabolic evaluation. So briefly to talk about kidney stone analysis, calcium oxalate is the most common stone in the United States. Second most common is calcium phosphate. And then uric acid is the third most common. This is one of the stones that we can dissolve. It forms an acidic urine. We can dissolve it by alkalinizing the urine. We can actually prevent these stones by alkalinizing the urine. It's interesting that it's radiolucent, meaning it doesn't show up on a standard x-ray. Sometimes that makes it more difficult to diagnose, but sometimes it makes it helpful to make that initial diagnosis if a stone is not easily visible. And interestingly, it's associated with gout. There is a lot of overlap with uric acid and uric acid crystals in gout. We see that in about 20% of cases. There are some infection-related stones. So struvite, that type of stone, is associated with infection, and these tend to be the type of stone that we see with staghorn stones, percutaneous nephrolithotomy. If we don't treat these staghorn stones, they can actually cause damage to the kidneys and lead to kidney failure, as well as recurrent or persistent infections. Occasionally, we see drug-related kidney stones. Ammonium acid urate stones tend to be associated with urinary tract infection, but also with abuse of laxatives. And there are also medications for HIV that can cause kidney stones as well. And then less commonly, I had mentioned earlier cysteine, which is associated with a recessive gene in the amino acid transport, where we'll see stones related to that, as well as hyperparathyroidism, which is involved in the regulation of calcium in the body. And then occasionally we'll see patients with renal tubular acidosis that are at high risk for forming stones. So, who should get this metabolic workup? First of all, patients who form kidney stones recurrently. Obviously, once you form one stone, you're at a higher risk of forming future stones. So, if you have multiple stones, we need to figure out why you're forming these stones and what can we do to prevent them from coming back or at least reduce the risk. High risk first time stone formers. So, patients that have non calcium oxalate stones, if there are some of these less common types, that usually indicate some type of metabolic abnormality. If someone presents with multiple stones when they initially present, so if someone comes in and they've got 4, 5, 6 stones on each kidney, that definitely would be someone who's higher risk for stone and would benefit from having a metabolic workup. Patients that have family histories, patients that have a solitary kidney are at higher risk because if they have an obstruction of that kidney, that can lead to kidney failure. And children, anyone, especially some of these younger patients, younger adults, they're at higher risk for having stones throughout the rest of their life. So if we don't correct some of these abnormalities early, it's something they could be fighting for decades. And then, of course, patients who are interested. There may be someone who passed a stone, it's their first stone, and they just want to know what can they do to prevent stones in the future, because most people would say that once you have one stone, they're motivated to not have another one. Patients are not happy, and it's not one of their better experiences in their life in terms of the pain and some of the discomfort associated with the stone or with some of the procedures that we do to get those stones taken care of. Who else should get metabolic workup? Well, those that have underlying medical conditions. So, metabolic syndrome, so patients with high blood pressure, diabetes, patients that have intestinal disease, so ulcerative colitis, Crohn's disease. If they've had bariatric surgery, they may have some absorption issues that can lead to dehydration and other electrolyte abnormalities. Hyperparathyroidism, so patients that have calcium regulation issues that could lead to excess calcium being excreted and forming stones within the urinary tract. Patients with bone disease, renal tubular acidosis, sarcoidosis, all those things related to the calcium as well. And of course, recurrent infections, as that could lead to some of those more complicated staghorn type stones. So, what's involved in the metabolic evaluation? Initially, we take a history. So, we want to learn more about the patient in terms of their medical history, their dietary history. It's important to know, as I mentioned, what type of stone, if we have that information available to us, if they have associated problems that could contribute, such as some of the absorptive type intestinal issues that could come into play, if they're taking any medications or supplements. I've seen a number of patients who take calcium supplementation to the point where it's led them to develop kidney stones because they're taking in so much calcium, their kidneys have to excrete it for them. And then there are social factors, occupational, family history, a number of things that can sometimes come into play in terms of risk factors for kidney stones. What is the metabolic evaluation? Well, as I mentioned, it's a 24-hour urine study and blood work, and you can see there's a lot of things that we're looking for, but I'll show you a nice printout in terms of an example of what we're looking at when we get that. But in general, we're looking at dietary factors, most commonly dehydration. I showed that big cup of water at the beginning of this part of the talk. Sodium, animal protein, calcium, and oxalate, obviously the most common types of stone being calcium oxalate. Those are things that we're looking at in the urine, as well as some blood tests as well. And then there's non-dietary factors. So the pH of the urine, as I mentioned, certain stones form in more acidic or more alkaline urine. Hypocitraturia, so citric acid or citrate is actually a preventer of stone formation. So that may or may not be related to the diet. And then renal leak hypercalciuria. The kidney just can't hold the calcium in and you lose calcium into the urine. This is an example of a 24-hour urine study. And I've circled the two things that are pretty abnormal in this patient, mostly being number one, the urine volume. So you can see this patient has a urine output that day of 1.13 liters, which is less than half of what that patient typically would be recommended to take in. Someone who forms stones, we'd usually recommend a minimum of 2.5 liters of urine output per day, which usually means you got to take in at least 3 liters of fluids because you're going to lose some bodily fluids from sweat. You're going to lose some water from sweat and other bodily fluids. And you can see that the patient had a low urine citrate level. The level of 307 is low. We typically want to see it in the 400 to 500 or higher range. Now, in this case, the urine pH at 6.6 is a little bit high, but that may or may not be related to the type of stone that he or she had. In general, for stone prevention, the low urine volume is the most common abnormality. The goal is to produce 2.5 liters of urine volume per day, taking in at least 3 liters. And then, of course, if you're physically active or you're sweating or you live in the Arizona desert and you happen to be sweating a lot that day, you probably need to take in even more than that. So that's a brief summary of some of the things that we talk about when I see a patient, going over the options for treatment, for prevention. But of course, we have to individualize it to the patient. And so there's a lot more discussion to have about prevention strategies in terms of medications, supplements, and all sorts of things that we can work on with patients to prevent these kidney stones. Hopefully, this was informative. I know it was a brief overview of some of the concepts that we look at when we evaluate patients that have current or have complex stones. Myself, my colleagues with Arizona Urology Specialists are happy to see and evaluate and treat any of the patients that have kidney stones. So appreciate you joining us.
Dr. Steinway is available for telehealth and in-person appointments in our Scottsdale office. For more information or to make an appointment, please visit us at arizonaurologyspecialist.com, where self-appointment scheduling is now available. Thank you so much and have a great evening.